acknowledge the effort of Mahfouz Shahawi in putting this program together. It's really a one-man and one-staff show here. He's worked at this assiduously for a long period of time, and I'd like to congratulate him on the success of planning this and carrying it out, Mahfouz. So you deserve the appreciation of all the faculty. Now, what I'd like to do this afternoon is to bring you up to date on the concept that I have told you about in previous years for those of you who have attended. How many are here for the first time at this meeting? Oh, great. Well, this is a program that I began 20 years ago, and it metastasized to Sarasota when we started coming down here for our annual winter solstice. And it has grown to the point that I believe it is ready for more widespread application. And as you read the recent literature in cardiovascular disease prevention, there is a real trend toward understanding the gaps that currently exist in the traditional use of methods to identify who is at risk. And our approach has always been different than the mainstream. And that has troubled many people because they are fixated on the message that comes from the Heart Association and the health departments and all the efforts to alter diet and exercise as an antidote to cardiovascular disease, when there is clearly another issue that is being unaddressed, and that is recognizing those individuals who are truly at risk. So let me, I guess I better do it this way. Well, are we advancing here, Ryan? What's going on? There's, this doesn't want to advance. All right, and now it's working, okay. Well, the traditional approach has been to use risk factors as a guide to who needs to be treated to prevent them from having cardiovascular morbid event. And those risk factors are predominantly blood pressure and cholesterol level, and the treatment is lowering blood pressure and lowering cholesterol. And the guide has been that anyone with a high 10-year risk for a morbid event, using either Framingham or the pooled cohort equations, which we now abbreviate as PCE, that is the more recent contemporary data on risk factors. Anyone who has a high 10-year risk by those equations should be treated, and that's the message that has been given to physicians. And one can either use a Framingham risk calculator. This is online, of course, for anyone who wants to put the data in. And the data predominantly relate to cholesterol and blood pressure. This is the algorithm for PCE calculation. Again, it's online, and you can estimate risk in your patient. And the guidelines suggest you should do this. And the general perception is if you have a greater than 7.5% risk for a morbid event in 10 years, then you should be offered some form of therapy to reduce your risk. Now, there are a number of fallacies with this, including those that the risk factor algorithm actually calculates risk accurately. But the biggest fallacy is the 10-year risk. As I show you data from our center, you'll see that the average age of our patient population is about 50. And I don't know of any 50-year-old whose horizon to protect them from a heart attack is 10 years. It's more like 40 years. And yet we don't collect data long enough in order to have an algorithm based on 40-year risk. And therefore, we're going to have to find an alternative approach. And tomorrow I'll be explaining to you our approach, which is prevention of disease progression. But today, let me confine myself to identify those who have disease and are in need of more aggressive management than is currently being offered. Now, how badly are we doing? Well, here's an example of how badly we're doing. These are patients who come in the hospital with an acute myocardial infarction. Obviously, they needed prevention. They've had an MI. So you would have hoped that they would be on treatment to protect them from an MI. And we have a lot of drugs now that have been demonstrated to reduce the risk of having a myocardial infarction. So why shouldn't these people be on therapy that could have slowed, delayed, prevented their myocardial infarction? Well, this is the incidence in which those people who had no prior history of a coronary event, therefore they were not aware they had a problem. If you've had a previous MI, of course you should be treated. But if you haven't had any symptom, then you don't know you're at risk. And your doctor apparently doesn't know either, because if you see those bars here, the bluish gray bars is the percentage of those people coming in with an acute MI who were either taking aspirin, a statin, an ACE inhibitor, or an ARB, or some combination thereof. And you can see the highest is aspirin, which was 20% of them. Statin drugs, which we know are pretty profoundly effective in preventing myocardial infarction, only 15% of the people coming in with an acute MI were taking the drug. So there's a gap here. We know how to do it. We're not doing it. So who should be treated? Well, anyone whose functional life will be shortened by a cardiovascular morbid event. What percentage of morbid events occurring in adults in the United States are due to cardiovascular disease? Events that would have been delayed or prevented had they been on appropriate therapy, at least based upon controlled trials that have been carried out. What fraction of the American population meets this criterion? Well, 30.8% of adults die from cardiovascular disease. So at a minimum, it's 31% who should be on treatment. But many others have cardiovascular disease which would have shortened their life had they not been hit by a truck or got cancer that we can't predict. And therefore, I think it approaches half the adult population who are at risk for shortened life expectancy from cardiovascular disease who should be treated. And there's really no other criteria, except that half the population probably has enough disease that either will kill them or would have killed them had they not died from something else. So my estimate is that 1/3 to 1/2 of adults need treatment. Now, what is the treatment? You go to your primary care doctor and your blood pressure is not high and your cholesterol is not extravagantly high. They'll tell you, well, exercise, lose weight. How many give that advice to their patients? Exercise and lose weight. I think it's higher than that. I think anyone who's a caregiver, how many are caregivers in the audience? Well, that may be the account for it. How many of you have been told by your caregiver to exercise or lose weight? What is the data on the benefit of exercise and diet on protecting people from heart attacks and strokes? None. If you went to the FDA and said, I want to have you approve exercise and diet to protect people from cardiovascular disease, they would not approve it. There is no data. The most aggressive efforts to document the benefit have failed. The biggest study was one organized by the NIH a dozen years ago that was reported out a year or two ago, called Look Ahead, which took 5,000 overweight diabetics who were just obviously at risk for heart attacks and randomly assigned them to aggressive exercise and diet or usual management. And the aggressive group lost weight, improved their exercise tolerance, had a better quality of life. I don't argue about the benefits of those things. They are there. But the heart attack rate was identical to the control group. So we're being fed a couple of messages which aren't consistent with the facts as available. One, that we're treating risk factors, and two, that treating risk factors will in fact protect you from heart attacks. And neither of those are documented to be true. So this then raises the issue, is there a better way to do this? And well, we'd like to think that there is. And this was the Rasmussen Center that we opened almost 20 years ago now. And what we do is look for early disease. And that's the same exact program that Mahfouz uses in his clinic here in Sarasota. A series of tests that are done in 1 hour by one technician in one room that identify any abnormalities of the large arteries, the small arteries, or the left ventricle, which are the cause of all morbid events. One of these, either it's your large arteries that got blocked up, or your small arteries which obstruct blood flow, or your left ventricle which gives you heart failure or sudden death. One of those organs has to be the cause of all cardiovascular morbid events. So what we do is we measure the elasticity of the small and large arteries. We measure blood pressure at rest and after exercise, because exercise brings out remarkable abnormalities of the blood pressure that are not detected at rest. We do a photograph of the retina to look at the small arteries in the retina as guides to small artery disease. We do a spot urine for microalbumin creatinine ratio as a guide to small artery disease of the kidney. And we do ultrasound of the carotid artery for intimal-medial thickness and for plaques. And in addition, we evaluate the left ventricle by an electrocardiogram, an ultrasound of the left ventricle to measure dimension and wall thickness and mass, and a plasma sample for NT-proBNP. Those are our 10 tests. We selected them because they assess the 3 target organs, the large arteries, the small arteries, and the left ventricle, because they can all be done in 1 hour, and they are essentially non-invasive except for the blood sample. Now that's what all our subjects have gone through. And then we give them a score based upon the tests, the 10 tests. If they're all normal, you get a score of 0. If they were all abnormal, you get a score of 20. If they were all borderline, you get a score of 10. So everybody has a score. They walk out and they get their score. Does that tell us more than we can learn from measuring risk factors? And that's an argument that I won't be able to solve entirely today, but I will show you the data that leads us to think that we are in the right direction. This is the distribution of Rasmussen scores in our center. These are all asymptomatic people who are just worried about their heart health. They have no symptoms. They have no heart disease. They haven't ever been told they have heart disease. They've had no events. So they're essentially a healthy subgroup of the population. And you can see that about a third of them have scores above 6. Another third have scores from 3 to 6, and 1/3 of them have scores of 0, 1, or 2, the first 3 bars there. That accounts for a third of the population, and we say they're normal, and they don't have any disease. But 2/3 of them have disease, 1/3 what we call early disease, and 1/3 of them with scores of 6 or above have pretty substantial disease, even though they are not symptomatic, and we think they should be treated. Well, here is the characteristics of this population based upon their disease scores. You can see 0 to 2 on the left, and the center panel is 3 to 5, and on the right side is disease scores above 6. And you can see there are about 500 people in each of these 3 columns, and the sex balance is pretty good. They're about 50% men and 50% women. Very few of them smoke. They tend to be on the heavy side. Their BMI is 27, 28, not terribly out of line. Their blood pressure goes up with the disease score, as you'd expect, but for the most part, these people have blood pressures within the normal range. Their cholesterol is really the same across all 3 populations and is not striking. Their LDL is 129, 28, not like that. Their glucose goes up with their disease score, but it's within the normal levels. And they have Framingham scores down toward the bottom, and PCE scores, which go up with the disease score, meaning that the risk factor assessment does in fact correlate with the presence of disease. And their disease score, of course, goes up because we've selected it that way. So that's your population, a perfectly normal kind of population you would get in your office, or that represents individuals in the audience who know their data. Well, now, we've managed to follow these people now for over 15 years, and here's what we found. 1,440 individuals without known disease, the patients I've just described to you. They all have the 10-test assessment of their cardiovascular health, and there are about 500 in each of the categories, 0 to 2, 3 to 5, and 6 plus. The morbid event rates over 15 to 20 years in the 0 to 2 group, 1.3%. In the 3 to 5 group, 7%. In the disease score 6 or above group, 11.6%. Well, I think you'd like to know if you're in the 11.6% category, because now you're substantially at risk. And yet most of these people are not being treated because they don't have any treatable marker. And their Framingham score and their PC score are not necessarily above the level where treatment seems to be recommended. So we're missing these people. They're having heart attacks and they're not on therapy, and they're said, well, it's bad luck. You had a heart attack. That's too bad, but it's a bad break. No, it's not a bad break. You had disease that's been progressing for 30 years, and you could have been on treatment to slow its progression, and you didn't know about it. So the screening that we do seems to identify the risk. Now, when you look at those with an event and those with not an event, as shown here, yes, the event group is a little older. There are more women, more men in the event group, rather. Not much smoking anywhere, and their BMI is not much different. Yes, their systolic blood pressure is a little higher, 133 versus 125. And that came up yesterday in the announcement for the American Heart Association that some of you may have seen. Now that we have a new criteria that blood pressure above 130 is abnormal, then all of a sudden half the population is abnormal. And the media says, oh my God, we didn't know that. We didn't know that because you didn't draw the line there before. Now we drew the line there, and oh my God, 50% of the population is at risk. Well, that is true, and 130 is in fact more commonly associated with disease than without disease. But many individuals with blood pressure of 130 have disease scores of 0 and are not at risk. So if you just use that as a categorical measure for treatment, you shouldn't be treating all these people, and the guidelines don't tell you to treat them. They say exercise and lose weight. Well, there is no data. So we're in the midst of a changing viewpoint about these things, and at the moment, most of the solutions don't make a lot of sense. Well, here's the graphs. Excuse me. Here's the graphs of those three groups, 0 to 2 on the bottom, 3 to 5 in the middle, and the group 6 or above on the top. And you can see the rate of events over 15 years is quite strikingly different. So we think we can actually identify the risk by identifying early disease with abnormalities of the arteries or the left ventricle. Now, here's a graph that may be difficult for you to appreciate, but I put it up here because to me it sort of tells you the story. These are the disease scores and the PCE risk scores in those patients who had a morbid event during follow-up. And you can see that if you look at disease score, which is on the vertical axis, there are only 6 patients that have disease scores that are below 3, which we consider the presence of disease. So only 6 events occurred in people with disease scores less than 3. But if you use the criteria for PCE of 7.5 or 10%, you can see to the left of the vertical line, which says PCE 10, to the left are all the people who had PCE risk scores that were within the normal range, telling you not to do anything about it, you're fine. And look at how many of them went on and had morbid events in the 15-year follow-up. So I think there is much evidence that the disease score provides a more sensitive guide to risk than does the risk score. And here's what happens if you take people with a low PCE, less than 7.5, which the American Heart says allows you to tell the patient you're fine, you don't need any treatment, you don't need to do anything. If you do a disease score on these people, those with disease scores above 3 in red have a pretty high risk for future morbid events, whereas those with scores less than 3 in the lower line, the green blue, have very few morbid events, and the p-value separating those two is very, very high. So I think we're at a point where we can say this is an appropriate way to go. So my conclusion is that nearly 50% of American adults are at individual risk for a CV morbid event. The current management strategy deprives a large fraction of these individuals from risk reduction therapy, and that early disease detection and monitored management can prolong life in as many as 50% of the adult population. And that's the future of cardiovascular disease prevention. Thank you very much.